Welcome, everyone. Thank you for joining me this afternoon. I'm excited for this opportunity to discuss some of my recent research on consolidation in the healthcare industry. This is a joint project with some others who were either at Duke previously or at Duke now. Paul Elison, he's at BYU currently. Ben Heaps at the FTC, they're both PhD students from Duke. And my collaborator, Jimmy Roberts, who's also at Duke with me right now. The big motivation for our study, we want to look at what's happening in consolidation in the healthcare industry over the past few decades. It's been a growing trend. We've seen hospital systems acquire one another, going from very spread out across the United States to just a handful of really major healthcare systems. We've seen it in insurance. We've seen it in physician practices. And we're going to look in dialysis. This is an important industry in the United States. That's also seen a lot of consolidation over the past 20, 30 years. Now, I'm an economist at Duke. My name is Ryan McDevitt. And I study economics in a special field called industrial organization. And in my field, we care a lot about how firms compete with one another, how that affects prices and quality for consumers. And in many studies that we've done over the past 50, 60 years, it's almost always the case that increased concentration in a market, meaning there are fewer firms competing with one another, that results in higher prices and lower quality. And typically in these studies, you look at market power, the idea that if there are only a handful of firms selling a product or providing a service, then they can charge high prices to consumers and offer them a pretty low quality because there's nowhere else for the consumers or patients to go. Now, in these studies, it's often the case that the competition, the concentration, is treated as a black box. We don't really know why we have these kind of effects. So in this study, we really want to drill down and understand why we have this change in price or quality in the setting we look at. And we're going to look at specifically dialysis. Well, there have been about 1,200 acquisitions of independent dialysis facilities over the past 20, 30 years. And two of the big chains now dominate. They own 2/3 of the industry. So in this study, we're going to try to understand what are the effects of this. Now that there are just a handful of firms supplying dialysis to about the 500,000 patients across the United States who need it, now that we're so concentrated, what are the effects? How does it affect patient care? How does it affect quality of life? And how does it affect spending in the healthcare system? Those will all be the major parts of our study today. Now I'll show you this slide here just to give you some background on dialysis. Dialysis performs a life-sustaining function for patients who need it. If you have kidney failure, your kidneys no longer function in your body. Well, that means they're not doing two things that you need to live. One, you're not filtering toxins from your blood, and you're also not stimulating red blood cell production. Now, of course, you need these to live, and so to replace those functions, you have two options currently. You can get a transplant, replace your kidneys, or you can get dialysis. And because we have such a shortage of kidneys across the United States, and not all patients are eligible, it turns out pretty much everyone in the United States who has kidney failure goes on dialysis for at least some period of time. Now, in the United States, the predominant modality for dialysis is called in-center hemodialysis, which you can see here on the screen. You go to a center. It's usually a small center with about, well, you see 15, 20 chairs there. You go there 3 times per week, 3 to 4 hours at a time. And this really affects your quality of life as a patient. It impacts your ability to hold a job. It affects your ability to have a family. Because you're there so often, it really impacts your quality of life. But you need it to live, and so really there's no other option once you have kidney failure. Now in the United States, Medicare is the primary payer for dialysis. And there's about 500,000 patients, 90% covered by Medicare. And there's a quirk in our healthcare system. By an act of Congress in the 70s, Medicare covers all patients in the United States regardless of age. So you see in the bottom of the slide, I made a little joke about it from a great John Oliver segment on dialysis. It's like one organ in your body in the United States is Canadian, your kidneys. In Canada, they have universal coverage of healthcare. We don't have that in the United States, except for this one exception, your kidneys. It's still a large burden for patients, even if they are covered by Medicare, because there's an 80-20 split under Medicare Part B. So this really adds up for patients over time. It can become quite costly. If you're fortunate enough to have private insurance when you start dialysis, they cover the first 30 months by an act of Congress as well. It's part of the law. And those reimbursements tend to be much more generous than Medicare. It can be 3 to 4 times as generous to the private chains that provide coverage. We spend a lot on dialysis in the United States. It's over $30 billion a year, 6% of Medicare's budget. And in fact, this is such a large slice of spending that it takes up 1% of the entire federal budget. That's just a staggering stat to me. 1 of every $100 I pay in taxes is going to dialysis. And as the population of the United States gets sicker and sicker each year, we see this population growing. So spending continues to increase year after year. Now, Medicare payments for dialysis is going to be a big focus of our study. They cover everyone, and they pay providers in a specific way. For the time period of our study, they had a blended rate where they paid centers, where you're going 3 times per week, $120 for each dialysis treatment. So you go in, you hook yourself up to a machine. Medicare then gives the center $120 for that. And on top of those composite payments, Medicare also reimburses providers a fee-for-service rate for any injectable drugs given during treatment. Now, the most prominent of those, we'll talk about more in a minute, is called Epogen. It helps combat anemia in patients. That's going to be a very large portion of dialysis spending during the time period we study. Medicare reformed this payment plan in 2011. We spent a lot of time in our next paper looking at the effects of this payment change. Here they bundled together treatments and drugs into one composite rate of $230. And we'll show you some of the effects, but you can see here in the figure below, there was immediate impact on the amount of injectable drugs given by dialysis centers to patients. They fell by almost half right after the payment reform, which suggests to us as economists that these providers are really responding to these financial incentives in ways that might not be tied to clinical care and the best outcomes for patients. A little bit more on EPO because it's so important in dialysis. It's used by over 90% of patients at any given time during fee-for-service. It's the largest Medicare drug expenditure over that time period. For instance, over $1.7 billion in spending in 2007 alone. The reimbursement was quite generous on a per dose payment, and it made a lot of money for the drug manufacturer Amgen, who held the patent during this time period, over $40 billion in sales, not just for dialysis, but a large part of that was for dialysis. And many of you may know about EPO from the blood doping scandal in cycling. Lance Armstrong, he was found to have abused EPO. It increases your red blood cell count, so it's very, very easy to abuse and use by endurance athletes. There is some leeway in dosing, which gives providers like DaVita a discretion in how much they give to patients. There's a targeted range for your blood levels. It's very controversial to go past that range, and I'll show you that some patients do go past that range. Their doses are too high. But this was such a large part of dialysis care during our study period that the largest chain, DaVita, 25% of the revenue is coming from just this drug and 40% of their profits. A little bit more background on the dialysis industry. There are 7,000 of these centers across the United States. You'll see they're often pretty small. They look like they could be in a strip mall. Sometimes they are. You'll see them scattered throughout a local community. And 2 large chains dominate dialysis care in the United States, Fresenius, DaVita. They own over 2/3 of the market at this point, and they're quite profitable. They make a lot of money, not just from dialysis care. They're in other parts of the healthcare industry, but dialysis is a large part of their revenue as healthcare providers. And part of the reason they've been so successful and have grown so much over time is they've been acquiring independent facilities throughout the past 30, 40 years. So think of an independent facility. This is a local doctor, probably a nephrologist, who started up one clinic, has 10, 20 chairs, maybe 100 patients. And then DaVita, the large chains, they own thousands of facilities. They've been scooping up all these independent facilities and making them part of their organization. And there are standard reasons to do that. We teach in business school. You might want larger scale, so you have economies of scale. You can negotiate better with drug companies like Amgen. You get better rates on supplies. You might have a large IT system where now you can spread it across many clinics as opposed to just one center. So a lot of positive reasons to consolidate. But the point of our study is, how does this then affect patient care? We know it might benefit the chains themselves who are getting bigger, getting stronger. But do they pass through some of those benefits to patients? That's the open question for us as economists. And it turns out strategy matters a lot for these dialysis chains. DaVita, for many years, led by a charismatic CEO, Ken Theory, MBA. He's been subject to many case studies. Harvard Business School wrote a large case study about him. Very eccentric executive. He used to dress up like one of the Three Musketeers for their corporate events, all for one for all, part of one corporate culture. And he had this great quote that I teach to my MBA students. He said, if I had 1,400 Taco Bells and 32,000 people worked in them, I'd be doing all the same stuff we do at DaVita. This is a very positive view of making healthcare more corporate. We can streamline procedures. Like I said before, we can have economies of scale. We can have different protocols in place. So patients know if they're coming into DaVita, they're going to get high quality care, whether it's in Durham, whether it's in Detroit, wherever it is in the country, we're going to get the same care, just like if you went to a Taco Bell. But one of the questions for an economist then is, should we be providing healthcare like we provide chalupas at Taco Bell? And that's not quite so clear, because healthcare is different, right? It's not like a fast food restaurant. Patients' lives are at stake. We have many different payers. Often the person getting the service isn't paying the bill. So we have reasons to suspect that maybe we shouldn't be treating healthcare just like we do other parts of the economy. Maybe there are reasons to do it, maybe there are reasons not to do it, and we'll look at some of the reasons of why we might not. So we're going to measure the effects of these acquisitions in specific ways. And the great thing about dialysis from an economist standpoint doing research is that Medicare provides all the data publicly available to researchers so we can analyze what's going on. And in a dialysis center, the patients are going 3 times per week, 52 weeks a year. So we have a lot of observation of exactly what's going on, both before and after a facility is acquired. I'll look at a few variables to see how those change after an acquisition. First, we'll look at injectable drugs. That's one of the most prominent, as I mentioned before, a large part of centers' profits, a big part of their business. We'll look at staffing decisions on the operations side. In dialysis, you go into a center, you can be treated by a nurse or a dialysis technician. Nurses have more training, and as a result, they're paid more. They can do more stuff. And so if you're trying to maximize profits, you're a for-profit center, you might want to have a few more technicians than nurses because you can save on costs and still get patients through the center each day. So we'll look at both the ratio of nurses to techs and just the overall staffing level. How many patients are being treated per employee at these centers? We'll also look at capacity. How many patients are they getting through the center each day based on the number of machines they have? You want to be really efficient. You want to get more patients through the center each day. That means you're going to get more reimbursements from Medicare. You're going to make more money at the end of the year. We'll then look at some of those choices by the dialysis centers and see how that then affects patient care and outcomes. We'll look at clinical measures. One's called the urea reduction ratio. That's simply how much waste is filtered from your blood during treatment. Another will be hemoglobin. How much do your blood levels rise or fall during and after treatment? We'll then look at more acute outcomes, hospitalizations, mortality, transplants. Will we see that these really acute outcomes, do they change after an acquisition? Are more patients going to the hospital, perhaps reflecting worse care? Are more patients dying? Are fewer patients getting transplant? Those are the key measures we look at in dialysis to talk about the quality of the care patients are receiving. So here's the main figure from our site. It's gotten a lot of attention in the press. We published this paper about a year ago, and this was a figure that everyone fixated on. This is what happens to drug doses for EPO after an acquisition. Now, there's a lot of statistics going on behind the scenes. We call it econometrics. But basically what I'm showing you in this figure is normalized before an acquisition. The dashed vertical line is when an acquisition happens of these independent facilities. Right before acquisition, for the first 24 months before an acquisition, right, 2 years, we see really no trend going on. Baseline is normalized to 0. And then after these independent facilities are acquired, almost immediately we see EPO doses spike up very sharply. In fact, when you do the math behind this figure, we're showing that EPO doses more than double right after acquisition. And what's really amazing about this study is because we have the same patients at the same facilities being treated before and after their center is acquired by one of the big chains, we can then look within these patients, so the very same patient, right, their facility owned by independent nephrologists on a Monday, and then owned by DaVita or another big chain on a Friday. But the very same patient going to the very same center, only thing that's changed is the owner of that clinic. We see drug doses spike by almost 100%. Right, so that's really telling to us that something's changed immediately after acquisition. The new owners are doing something different. In regression form, if you like to nerd out on this stuff, this is what I do every day in my office alone. If you do a regression of this, everything holds up. Your eyes aren't deceiving you there with a picture. Everything is statistically significant. The way to interpret this, look at column 1. That's epogen as the dependent variable. We do this regression. Pre-acquisition, these independent facilities, they're giving slightly more EPO, a little bit more than any other independent facility that's not acquired. But then post-acquisition, you see in the second row there, spikes up to 1.529. That converges to the rate at the facilities that are always owned by a chain. So that's how we know that they're using their standard procedures, their standard protocols. They have operation manuals at the facilities. They know for a given patient, their characteristics. They know how much EPO to give that patient. That's what we see here is happening. It's not just EPO. We see this across many different factors of the dialysis clinics. Another injectable drug, IV iron, where you need more iron if you're anemic and your kidneys have failed. Well, there are two options for dialysis clinics to treat this IV iron. One is Ferlicet, gives a low reimbursement by Medicare, Venofer a high reimbursement, just through some quirks in the reimbursement scheme. But we see immediately after acquisition, these same facilities that are using a lot of Ferlicet before acquisition, all of a sudden switch to Venofer in order to get the higher reimbursements. Another quirky anecdote about this, it turns out clinics have been exposed for wasting drugs. They'll take, for instance, 4 vials of Venofer. They'll take 25% out of each one, give that to the patient as a dose. And then because Medicare reimburses by the vial, they're throwing out 75% from 4 vials. They can bill for 4 instead of 1, and that was very lucrative. But unfortunately, it's illegal for the clinics, so they were then exposed in whistleblower lawsuits that had to pay a lot of fines as a result of this behavior. Looking at more of the input side, the nurse-tech ratio I told you about before. Remember, nurses higher skilled, but higher pay. Well, we see that ratio fall about 15% right after acquisition. There's about a 1-to-1 ratio on average of nurses and techs. Well, it's 15% lower right after acquisition. We also see them putting more patients per employee, goes up by about 12%, and more patients per station, up by almost 5%. So they're stretching resources. That's what you want your for-profit business to do. So we teach you in business school and operations class, get more output from the same inputs. But in healthcare, there's going to be important trade-offs, and that's going to come at the expense of patient care, which I'll show you in a moment. So if you look at what happens to these outcomes, we see hospitalizations go up after acquisition. They go up 6%. Now, these patients are very vulnerable. They're at risk. So even just small change in the quality of care manifests that in more hospitalizations. Some of the most severe ones, blood infections, those go up 13%. Cardiac events, 4%. And the cardiac event, the heart attack, that's probably directly related to the EPO doses. High EPO doses, one of the main side effects is you're more susceptible to heart attacks. We see that then happen right after acquisition. And remember, for our study, we have Medicare data. We're looking at the same patients before and after. This is the very same person after acquisition is now more likely to have a heart attack. For some of the clinical outcomes, we see a mixed bag of evidence. The good URR range, that goes up after acquisitions. That's one of the good things these chains are doing after they acquire the independent facilities. They're keeping on the machines long enough to clean their blood. Low hemoglobin rates fall, but that's kind of a double-edged sword. It's great that the low hemoglobin rate is falling because it impacts the quality of life for a patient. They're less sluggish, they feel better. But they're doing that by giving them a lot of EPO during this time, which then has a bad outcomes for cardiac events. And you see the high hemoglobin rate goes up. And so the nephrologists we've consulted, if you want to pick low hemoglobin versus high hemoglobin, you always want to err on the side of low hemoglobin because the side effects are much less severe for patients. And next, we look at probably the most important statistics for a dialysis patient. How long do they survive on dialysis until they can get a transplant? And here we see some pretty bad outcomes after acquisition. A patient at the same facility after it's acquired is about 9% less likely to be put on a wait list or transplant in the first year on dialysis. And they're also 1.7% less likely to survive. The death rate is very high on dialysis. These patients, again, are very vulnerable, very sick population. About 25% die during any given year on dialysis, and that rate gets even worse after these independent facilities are acquired by one of the large chains. And then the final figure to look at, Medicare payments go up about 7.5% right after acquisition. As a result of these higher drug doses and some other things that the dialysis chains can move around to be more lucrative, we see those payments go up quite a bit. So that's why they're doing this. They're for-profit companies. They're in business to maximize returns for their stakeholders. They're doing what they're designed to do. Unfortunately, that comes at the expense of patient care. Patients are faring worse while these chains are earning higher profits. So that's in a nutshell our paper, our research. The main takeaway for you all today is that financial incentives do play a very large role in patient care. That's pretty obvious. Right? You didn't need to come on a Wednesday afternoon to learn that from me. But probably the extent to the degree to which they matter, that's maybe less obvious. And in healthcare, remember, we really care about maximizing both our expenses as a system and the care that patients received. And we find here that chains, although they're very savvy and sophisticated at maximizing profits, often it's coming at the expense of patient care. And the last thing that we'll highlight in our paper and our research, as economists, we care a lot about something called antitrust. Should we let these big chains consolidate even further? Should they be able to acquire all these independent facilities if we found that they're not providing the best care possible, if independent facilities were providing better care? That's less obvious to us, and it's more than just market power going on here. In an appendix in the study, we look a lot at how local market concentration determines the quality of care patients receive. Remember, I told you on the very first slide that as economists, we care a lot about consolidated industries because they increase prices and reduce quality when they have a lot of market power. Well, at a local level, we don't see that happen in dialysis. It's not the main explanation for what's going on. Okay. What turns out to be happening is that these big chains, they have a specific strategy. They have these operation manuals, they have the procedures, the protocols. They're giving patients the very same care, regardless if there's a dozen firms in their market or just one. They're going to provide the same type of care. So it's really the strategy, the overall corporate strategy of the dialysis chain that's dictating patient outcomes. And so for us, a better solution than antitrust remedies would be to get a better payment system for Medicare, which can lead to better results at a lower cost. And that's a big part of our most recent study. It's under peer review right now. We look at what's happening to dialysis clinics right after this payment reform, where they switched from fee-for-service reimbursements for injectable drugs to the bundled rate where everything's together. And that's an interesting aspect to study because it's taken EPO and some of these other injectable drugs from a pure profit center for facilities. The higher the doses, the higher their profits. Now it's pure cost. The higher the doses, the lower their profits because they're not getting any extra reimbursement from Medicare, while at the same time their costs are going up as they're paying a per dose cost to Amgen and some of the other suppliers. So teasing apart those trade-offs, I'll give you a little preview of what we find. They overshot in reducing EPO. Some patients are faring a lot worse as a result of that, although some are better off. So there's some heterogeneity in how the patients respond to the change in dosing behavior after the payment scheme changed. That's all I have for my presentation. Thank you so much for joining today. I'm happy to open up for any questions in the audience. I see a couple populated here in my screen. One was about what we should do from an antitrust standpoint. Should we regulate these mergers? And why hasn't the DOJ, FTC stepped in? And I think a big reason we haven't seen much regulation so far is these acquisitions are very, very small. So think about just an independent facility, one clinic being purchased by DaVita or Fresenius. This is a $4 million, $5 million transaction, $10 million at the very most. This doesn't get the FTC or DOJ involved. You need to have multiples of that before you'll get any kind of scrutiny from antitrust. These are kind of flying below the radar, so to speak. So they're just not designed to regulate these small one-off transactions. I really think it's up to Medicare right now as the primary payer for this to step in and offer better incentives to providers to have outcomes more directly tied to what the payments for the facilities are going to be. And we're seeing some of that. They do have something called the Quality Incentive Program that was implemented around the time of the payment reform. So we're starting to see some of that. It hasn't had a lot of bite right now currently, but we're going to see more of that as these facilities have more and more profits at stake. They'll respond more to these incentives. Again, another question about the growing consolidation in healthcare, what can be done? I think at a broader level across the country, we really do need to have more antitrust scrutiny. We need to start blocking more of these merges. The theoretical benefits that could occur after this, the economies of scale, the better coordination of providers, having the same IT system for your local primary care doctor, and then going in after your heart attack. Those are theoretical benefits. We just don't see any evidence of that happening. And when we get the data after all these changes, we haven't seen anything that's really benefiting patients. It's really the firms increasing their market power, the hospital system, a dialysis chain, these practices. They have more market power in the community. They can charge higher prices. That's ultimately paid by your insurance, and your premiums are going up. So we see a lot of profits flowing to these hospital systems and other healthcare providers. We haven't really seen any benefits on the patient care side. So I think that's the trade-off we're accepting right now in society, and we might not be willing to do that much longer. We really need a wholesale reform of the system. Well, I don't see any more other questions coming in, so thank you so much for joining today. I really get excited to share my research agenda with my colleagues and collaborators. We are very active in this space, so if you have any other ideas, studies you'd like to see, please shoot me an email. I'm always happy to consider that. And if you're considering Fuqua, you were really, really active in the healthcare sector. We have a program called Health Sector Management Concentration. About 100 MPAs a year sign up for that concentration. We have some of the best faculty in the world. David Ridley looks a lot at drug development. He's an expert in that. Peter Ubell looks at more of the behavioral side of things. Really, really fascinating people to work with, great class to take. So please consider Fuqua if you're applying to business school programs in the near future. And if you liked the segment today, next week we'll have another one. My colleague at Fuqua, Jillian Grennan, she's in the finance area. She's going to talk about our very recent research looking at the consequences of what they call common ownership and entrepreneurial strategies. Common ownership means that some big funds, think of your BlackRocks, your State Streets, they own a bunch of companies in the same industry. That means they're going to be less competitive. They're going to fight less with one another for profits, for cutting prices. What does that then relate to entrepreneurship and entrepreneurial strategies? She'll be able to share some research on that next week at the same time. So thank you so much for joining me. It was a pleasure to discuss this with all of you, and I look forward to seeing you at Fuqua in the near future.